Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss about a patient who presented with an ingestion of some unknown pesticide. A 62-year-old male patient was rolled into the ED in an intubated state, and there was a history of pesticide intake 5 hours back. So, in the initial 10 second, in the primary survey, patient's airway was secured with a 7.5 size ET tube with an angle of mouth kept in 20, and there was good fogging in the tube, and there was no secretion through the tube, and cuff pressure was 32, and there was also an OPA. C-spine was orpharyngeal. Since it is a unknown ingestion pesticide case, so we secured a C collar and shifted from the trolley to the ER bed after log rolling, and quick C-spine examination was done, and there was no gross deformities.
Okay. So at this point, let's see regarding the airway. So you think an adult male patient,
yes,
7.5 size ET2, is it acceptable, or you wanted to change the tube at just a point of time?
7 size males, we can go 8.5 will be good enough for them. It will be somewhat a small size tube, but I don't want to change it now.
What could be the reason why they have gone for a 7.5, or just accidentally they just put 7.5? What do you feel from this?
Maybe there might be some secretions or anything. There was difficulty in visualization because of some secretion. Anyway,
visualization 7.5, 8.5 won't be a big difference.
Taken some some ingestion is there. If you had aspirated the vocal cord edema, we are not sure.
Okay. Ideally, we should have a referral note saying what has happened to this patient there, and just receiving a ventilated patient, we will not know anything. But from the background history, 7.5 size ET2 is not correct for this patient. Either of this reason, by accidentally, whatever they have got, they have intubated with a 7.5, or due to some other reason, whether they have intubated with a 7.5, like as you said, laryngeal edema, we don't know. So that is one thing that we need to keep in our mind. So once we are, the patient is in, as you said, no need to change the tube immediately. So what are the anticipated problems for a smaller size ET2?
Yes. So there can be, because of resistance will be more, because as radius reduces, resistance will be 4 times that of that. Okay. So then secretions might get lodged in that. So
if resistance increases, what is the problem?
There will be compliance will be reduced. There will be difficulty in achieving the tidal volume.
Difficulty in achieving the tidal volume, that will be the initial one. Difficulty in achieving the tidal volume. Secretions clear is 7.5, 8.5, not major difference, but still it is not right. The main problem that we will have to anticipate will be the resistance that is going to increase, and as a result, the tidal volume delivery. Sabrish, anything to add? Yeah. So 7.5 ET2 then? Continue.
Yeah. Then breathing part, he was brought in with ambu ventilation with 10 liters of oxygen, and air entry was bilaterally equal. There was no added sounds. Saturation, he was maintaining 100% with ambu ventilation, and ETCO2 was 28.
Just there was no crepitations. So what does it indicate?
It is a case of unknown pesticide ingestion. So usually there will be, if it is some OP poisoning and all, there will be bronchuria and excessive secretions will be there. And if the patient has vomited and all aspirated, there might be secretions. Okay. So that there can be crepitations. And since this patient is an intubated patient, we can confirm the position of the tube by air entry. Checking there.
And ETCO2 we have done, and ETCO2 was 28. So 28 ETCO2. One thing that is sure, either they have given outside atropine. Right now there is no secretions. And what was the heart rate?
Heart rate was 115.
115. What was the pupillary size?
Pupil size was 2.5 millimeter, equally reactive.
Oh, so they have not given any atropine. So we don't know, but usually 2.5 and all, it will be a normal pupillary reaction response. So 2.5 and heart rate is 115, and there is no secretion. So it is dry secretions. So probably we are not dealing with the toxidrome of excessive secretion. So whichever is then, we are not dealing with an OP or a carbamate. That is one clue that we can get it from the details what we have got. Then
So circulation, but his heart rate was 115. His blood pressure was 90/40 with a map of 50. Peripheral pulses were felt equally, but it was feeble. There was no external bleeding for this patient.
Okay. So what was done at this point of time?
So already 2 large bore IV cannulas were there for this patient. Quick IVC was checked and IVC was 0.8 centimeter collapse. So we gave him 2-pint normal saline boluses was given, sir.
Okay, 90/40 was the BP. So we have given 2-pint bolus of normal saline. Around 1 liter was given to him. And what was happened to his BP?
Then after that also his BP was on the lower range, and when we checked with the ABG and all, there was lactic acidosis was there. So hypotension was there. So we had to start him on noradrenaline.
Okay. So, anything else? Okay. So we have a patient who have come with an unknown ingestion with intubated. So there was some problem in the airway. We don't know what was the reason behind intubation. There was some problem with the A or B. Doesn't look like a problem with B, because as such now air entry is bilaterally equal. You are able to achieve a very good saturation, and some problem with the A. Maybe to secure the airway they have gone ahead and intubated. And what was the sensorium for him?
Sensorium was E2 VT M5 and patient was struggling against the ventilator.
Okay, so we don't know what was the sensorium at the time of intubation, and we
don't know the last dose when the sedation
was
paralytic was
okay.
given.
So from this, whatever is the only thing what we are having is a hypotension and some amount of tachycardia. That is the only
because
thing.
of pain and struggling.
Now the patient is restless and most likely you are going to sedate the patient, right?
Yes.
So you want to do anything before that?
Before that, we can give an analgesic for him. Low dose of analgesic fentanyl can be given. Sedative at present I am not preferring, because we have to take the toxicology samples, and also it will be positive for sedate initially itself. And paralytic agent also we should be very careful, because if it is a POP and all, we should avoid depolarizing agents.
See, one thing is that very sure is that some agent he has consumed and he has come with hypotension.
Yes.
That is the thing that we have right now. So it doesn't look like fitting into an OP toxidrome or a carbamate toxidrome. There is no excessive secretion. Hypotension. So when you have a hypotension, what are the possibilities that you need to keep in mind?
It can be a beta blocker overdose or a calcium channel overdose.
But liquid preparation, he is telling that he has consumed a liquid preparation. So what could be the other reasons? Anything else that can cause hypotension? Any other agents we can just commonly go through? As you said, beta blockers and calcium channel blockers can cause. What does oxalic acid do?
Oxalic acid also can cause vasodilatation. And
oxalic acid again is one of the agent. Again, it's a corrosive agent, but still very unlikely to cause the direct hypotension. You can have hypocalcemia and resulting in a cardiac dysfunction and hypotension. So that is one thing. Something myocardial depression is happening here.
Yes.
Whether it is a direct or indirect, we don't know. What we have to keep in our mind, because in liquid preparation he has taken, he can take some tablet and after that he can drink some liquid. We don't know. But whatever be the thing, only thing that what we have in our hand is hypotension. So hypotension, reason for hypotension we are not very sure. Whether it is due to a direct toxin that is causing the hypotension, whether there is something else that is happening, whether there is due to the stress, whatever he have been developed, and he have developed a stress cardiomyopathy and he is developing a cardiac failure hypotension, we don't know. But peripheries were warm or cold?
Peripheries were pulses were actually feeble,
no,
but
I am asking cold. So you are dealing with a cold periphery.
Cold.
So cold periphery, hypotension, most likely it can be a stress cardiomyopathy. We are not very, some tachycardia is there, some amount of tachycardia, some amount of hypotension is definitely it is there, and you have little bit of increase in lactate. So he came into the hospital after how many hours?
5 hours.
5 hours post ingestion. So lactate can be a direct toxicity causing a lactic acidosis will take time, because something going and causing lactate, it might take time, but here it might be due to the hypoperfusion and hypotension. So we have to see what is the reason behind. We only have got some clues that lactate is high. That can be due to different reasons. You have got hypotension. Only our aim is to tackle that hypotension. You said it is refractory to your IV fluids. So you need to start on noradrenaline infusion. What happened after noradrenaline infusion?
After noradrenaline infusion, his BP started improving, sir. We will move on to the disability.
Yeah. Sorry, okay.
So his GCS was E2, VT, M5. He was irritable and struggling against the ventilator, and pupils were 2.5 millimeter bilaterally equal reactive. And there were in the disability part and exposure, when we checked, there was some kerosene-like smell coming from his oral cavity, and already there was decontamination. Stomach wash was done from outside hospital when he was taken there, and exposure's temperature was 90° Fahrenheit.
Any gastric, this thing charcoal was given?
No, it was not.
Not given. Charcoal was not given, stomach wash was given. So when somebody is receiving a stomach wash, they are ruling out probably a corrosive ingestion or a heavy metal ingestion or something that is generally contraindicated. We will not do a stomach wash. So somebody has done a stomach wash in the sense he has not probably ingested a corrosive agent. So that's only one thing. They have done it properly. So, okay.
GRBS was 136 milligram per deciliter, and hypothermia was prevented by blanket. And adjuncts, we have, since it is a suspected pesticide ingestion, we have approached the patient after wearing proper personal protective equipments, rubber gloves and eye protective equipments and proper shield.
You said regarding a kerosene-like smell.
Yes.
So why it is having a kerosene-like smell?
Maybe it is, this pesticide was preserved in that agent.
Okay, usually they will have what we call as a vehicle. All these pesticides needs a vehicle to be delivered. So usually they mix this either in kerosene or either of this petroleum distillates. So that is a typical smell why we are getting this, and majority that garlicky sort of an odor hardly I have not seen for any of this patient, because already it will be mixed with the vehicle. We will be getting some petroleum like smell or a kerosene like odor. That's the usual this thing will have. And other thing that can mask here, the pupillary this thing, suppose this patient has consumed alcohol along with it. Suppose he's taken alcohol and this pesticide along with it. So what can happen?
So if it is depending on if it is a methanol or ethanol. So
no, I'm asking a plain alcohol, ethanol. Just ask what is alcohol does. It increases the
absorption of that.
No, it increases what? Heart rate and pupils. What will happen?
Pupil construction can happen in ethanol.
Sympathetic activity will be
increased. So what will happen?
Pupil will be dilated.
Pupil will be dilated. Heart rate will also be increased. So that can counteract whatever agent that he has consumed. So sometimes we are classically telling regarding OP induced bradycardia and OP induced pinpoint pupil. It can be masked due to the other agent that they have consumed, maybe an alcohol, or sometimes they can have autonomic dysfunction also. So always we will not get that clear-cut picture. But one thing it is very clear: there is no secretions for him. The secretions were clear. Here either they have given atropine from outside, we don't know. But if they have given atropine to clear the secretion, the pupil should have dilated. And the next thing is that he has got some amount of tachycardia. So tachycardia can be attributed either due to the pain, as you have mentioned, or due to the co-ingestion whatever he had. So it can be a mixture of both the agents. So it will be very difficult to fix into a single toxidrome.
We initially gave 25 microgram of fentanyl because he was struggling against the ventilator, and we started on 20 microgram per hour fentanyl infusion. And then he was
before that you have taken the samples?
Sorry?
Before that you have taken the samples?
Toxicology samples.
After we initially corrected the airway part, we have ABC management. Initially we connected him to the ventilator, put him in PCV mode. Then
so the question here is that whether
toxicological
Sedatives
samples
were given after or before toxicology sample.
No, were toxicological samples collected? If yes, what were the samples collected? That's a question.
Toxicology samples were collected from the blood. Then urine and the Rayleigh tube content was taken, sir.
Okay.
So
any other medical legal implications at this point?
Clothes and these things should be preserved, and we should look for any other injuries also. And samples,
the message here is that you need to send your toxicological samples out before you start sedating.
Yes.
So you will miss something, as you mentioned earlier itself. We should not miss that agent. So basically, which all toxicological samples, what all tests we need to send. So it's a big question. Which all panel we should ask for. So what we are suspecting, we can just talk with the clinical toxicology unit and let them decide what all tests needed to be done. You can clearly explain these are the clinical features what we have got, and depending upon that they can run a test. So what clues we have? He has taken some pesticide, herbicide, or whatever it is, something he has consumed that. And second thing, he has got some amount of hypotension and a little bit of tachycardia, and pupils were equal. That's the only indication what we have got right now. And blood, gastric aspirate, and urine. These are the common 3 agents that we need to send for evaluation.
Usually for toxicology, we will be taking in the red vacuole, and for checking, since it is a pesticide, we will have to check for the pseudocholinesterase level also. For that, we will have to take samples in the EDTA vacuole.
EDTA vacuole. So that is again those who are practicing and sending samples to an accredited lab, they should be aware of this red vacuole and the EDTA vacuoles.
Then his ABG was taken. ABG was showing a pH of 7.263 with a PCO2 of 32.8 and bicarbonate of 14 and lactate of 9.7. And anion gap was 18. There was a lactic acidosis in that, probably because of hypotension or hypoperfusion.
Just metabolic acidosis, high anion gap metabolic acidosis alone, adequately compensated, or you want more compensation, or there is associated respiratory acidosis.
Compensated.
What was the bicarbonate?
14.
What is the expected bicarbonate? 29 plus or minus 2 should be around 30. What is the bicarbonate here? Sorry, PCO2 here. Expected PCO2.
32.8.
32. It is almost the same. So it is compensated high anion gap metabolic acidosis. That's what we have right now. So it is adequately compensated high anion gap metabolic acidosis. So high anion gap metabolic acidosis, what should be the next thing that you should be doing when you are seeing an high anion gap metabolic acidosis?
Osmolar gap.
Osmolar gap. What is the osmolar gap
25.
here? 25. High osmolar gap. So what should be the next investigation that should be asking for?
Methanol and ethanol levels should also be checked.
Methanol level, most importantly, we have to keep in mind, it can be as you said, they have mixed with methanol and they would have consumed this. So methanol toxicity and metabolic acidosis, this amount of metabolic acidosis, that should not happen in a normal pesticide ingestion. So there is something else he have consumed that is causing this metabolic acidosis. So you have to go, maybe 2 injections will be there, we don't know exactly.
So we went ahead with the ample history. There was no allergies. Patient was not taking any previous medications and no surgical history. Last meal was 12 hours back. Patient uses alcohol on a daily basis, both alcohol and toddy. And he had some conflict with his son on the previous day. And on the day, wife noticed multiple episodes of vomiting after drinking alcohol around 7 p.m. And that vomiters had a peculiar kerosene-like smell. And patient was gradually became very drowsy and he was taken to outside hospital, and in view of low GCS they have intubated him, and suspecting an OP poisoning they have given 1 milligram of atropine and 2 grams of PAM was given from there, and that was all written in the referral letter. And patient was referred here. On the way, son got an information from the neighbors that patient bought a bottle of Bumber, agent named Bumber, which is containing 25% propiconazole, which the patient bought from a nearby shop around 4 p.m. So that history.
4 p.m. he has brought, and consumption is around?
That we are not sure, but patient was found vomiting and all at around 7 p.m.
Okay.
There was no other history of deliberate self-harm previously. There was no diarrhea, involuntary maturation, or any seizure activities in that.
Now we will come back to our clinical presentation. So let's see what will be the reason for each one of this. Why this patient had a hypertension? What could be the reason?
Maybe patient had multiple episodes of vomiting, so hypovolemia can be a reason. Then patient was drowsy when taken to outside hospital. So lactic acidosis might be because of hypoperfusion or seizures.
Okay.
Then
or he is an underlying chronic alcoholic.
Yes.
So chronic alcoholic, already the liver function is deranged. On top of that, he had consumed some agent which can cause liver failure, as well as it can cause acidosis also. So that might be the reason for his hypotension. On top of hypotension, so that is the reason for his lactic acidosis. So in liver failure, the lactate clearance will take a longer time. So again, that will be the reason why he had developed this lactic acidosis. So hypotension we have got an answer, lactic acidosis we have got an answer. Then what else he had? Low GCS maybe due to recurrent vomiting and due to the effect of alcohol, his sensorium would have dropped. They have intubated. Still we haven't got the answer why they intubated using a 7.582. That is the answer still we don't have from the referral letter. But rest we could attribute from whatever history we have got. Okay, fine.
So head to foot examination, before that we examined the vitals again. That after starting noradrenaline, his BP improved to 110/70, heart rate was 105, and saturation he was maintaining 100% with 30% FiO2. We examined 4 other injuries which were absent. There was no other abnormal movement seen for this patient. In the CN GCS was E1, VT, M1.
We have sedated him with fentanyl also.
Yeah.
So,
Then other system examinations. Cardiovascular system examination, first and second heart sounds were normal. Echo was showing good value, and ECG was also taken. So it was showing a sinus tachycardia with a QTC of 413.
why QTC? Why you have specifically told regarding QTC here?
Any QTC prolonging agents.
Which agent?
Any antipsychotic agents.
Okay.
Haloperidol and all.
Okay, all those agents we should be very careful whether he has taken for the antiemetic that we commonly use ondansetron. So it can again increase your QTC. So just wanted to make sure that its QTC is normal. Okay.
Chest was clear, then also chest was clear, air entry was bilaterally equal, and per abdomen examination was also within normal limits. So systemic examination, from that we didn't get anything. So patient in the management part, his airway is already secured, and gastric decontamination, gastric lavage was taken from outside. We have already taken the toxicology sample and sent for analysis. We've connected him to cardiac monitors and continued on noradrenaline infusion, and we will have to also give thiamine, vitamin supplementation because he is chronic alcoholic.
Thiamine, how much you wanted to give?
Since he is chronic alcoholic, we will have to give 500 milligram thrice a day for at least 2 to 7 days. Then we can give 200 milligram BD dose. Then we have counseled the staff regarding the use of personal protective equipments. Even though if patient passes stool also, that should be taken care of.
But right now, once you know it is propiconazole, unlikely it will have a skin absorption. So it's a direct, it is not an OP compound. So it's an antifungal agent, what you have consumed. So antifungal agent, again a heavy dose antifungal agent, that will cause liver failure. So that is the only thing that would have happened to him. So,
and pseudocholinesterase level also was within normal limit. And toxicology results showed propiconazole in the gastric sample, and alcohol in blood, urine and gastric sample, and trace amount of methanol in the urine.
Trace amount of methanol in the urine.
So he is having a metabolic acidosis, so methanol also might have contributed.
Okay, so whether at this juncture, what will be your management plan?
In the follow-up ABGs, he had this persistent metabolic acidosis. So we will have to plan on removing that. So we planned him on a hemodialysis, and dialysis was done.
Okay, so I have to think of an extracorporeal removal. What would be the ways? Methanol is one thing that can be removed via dialysis. Or the problem here is that he is also having metabolic acidosis, severe metabolic acidosis. So to tackle that, we need to definitely go ahead and dialysis him. So dialyzed, what happened to him? He was dialyzed.
He was dialyzed. After that, his metabolic acidosis improved. After starting noradrenaline, anyways, lactate and everything improved, and we were able to gradually taper and stop that.
Now, what are any specific antidotes for this propiconazole?
No, sir.
What was this LFTs?
LFTs was bilirubin was it was normal only, sir.
INR?
INR was 1.1.
Any role for your N-acetylcysteine here?
Yes, for N-acetylcysteine, the definitive indication is for paracetamol poisoning, but we can give N-acetylcysteine off-label use solely there, sir.
Okay. Fine.
Then after that, his ABG improved. Then we were able to wean him off the ventilator, and we were able to extubate him. But the next issue was he was facing this alcohol withdrawal features were there. So
you have transferred him to psychiatric
care.
Okay. Okay. Fine.
Okay.
Thank you.